Hey everyone, welcome back to Nurse Crit. My name is Chasen. I'm an acute care nurse practitioner. Is your ABG making you feel sad, confused, and drained? No, I ain't talking about your Asian baby girl. I'm talking about arterial blood gases. The ABG is truly an amazing tool that yields immensely valuable information about a patient's physiology. I know critical care nurses see blood gases all the time, but even non-critical care nurses should be familiar with basic ABG analysis. Let's do a review together on ABG concepts, then we can practice interpreting a few ABG cases later in the video. In this video, we will identify the uses and limitations of blood gases, differentiate between emia and osis, understand oxygenation and ventilation, review acid-base balance and the four derangements, and practice interpreting basic ABGs and compensation. What is a blood gas? A blood gas is a simple test that healthcare providers use to aid in the diagnosis of medical conditions and guide treatment decisions. A blood sample is drawn from either an artery or a vein and then processed by a blood gas analyzer device. The most common arteries sampled are the radial, brachial, and femoral. Blood gases provide useful information on the patient's oxygenation, ventilation, and acid-base status. We know from anatomy and physiology that arteries carry oxygenated blood and veins carry deoxygenated blood. So although an ABG and VBG both measure the same parameters, we can expect that the oxygen values will be much higher on an ABG and much lower on a VBG. If you need to accurately assess the oxygen status of a patient, you must obtain an ABG. However, if oxygenation is not a primary concern, a VBG can be used instead to assess acid-base status. So why not just get an ABG every time then if it provides the greatest amount of information? Well, unless the patient already has an arterial line in place, performing a de novo arterial puncture tends to be more painful than a venous blood draw. Also, a VBG can be obtained at the same time by the same person with the same blood as the rest of the blood tests that have been ordered. That can potentially save some time and manpower, since at most hospitals, only respiratory therapists or advanced practice providers are allowed to perform an arterial stick. Despite these perceived benefits, I estimate that we still use ABGs over VBGs 98% of the time, probably because almost all research studies are based on the ABG. And I also think that it just makes us feel better. We love having a bunch of data points in the hospital, even if they aren't helpful. But maybe if we all had to experience an arterial stick, we might not be so cavalier about getting ABGs. Just my 2 cents. As great as ABGs are, they do have some limitations. Because it is a blood test, it's merely an intermittent snapshot of a patient's condition. It doesn't provide real-time information like values on a cardiac monitor. If a patient is coagulopathic or on anticoagulants, achieving hemostasis can be challenging with frequent ABG draws. Arguably worse than bleeding is the opposite problem, thrombosis of the artery, which can compromise blood flow distally. Even if you have an arterial line, if you don't use a vamp or other closed system device, you will have to waste 5 to 10 mLs of blood with each ABG sample and potentially worsen an anemia. Anytime we create an iatrogenic break in the skin, infection is always a possibility. And lastly, ABGs are just frickin' expensive. I believe most hospitals charge around $300 to $600 for a single ABG. Imagine being a critically ill patient who gets multiple ABGs per day. If you have a diagnostic uncertainty and need guidance with clinical decision making, absolutely get an ABG. But if you have a patient who's breathing 40 breaths per minute, using accessory muscles, and is satting only 82% on the monitor, you don't need an ABG, you need an ET tube. The ABG is not going to provide any additional value in this situation. I would also argue you don't need daily ABGs for a patient who is stable for days on the same ventilator settings. Just save the ABG for when you conduct the spontaneous breathing trial. Before I move on to the next topics, I need to discuss the components of an ABG. Every ABG provides the following information: the pH, PaCO2, PaO2, HCO3, SaO2, and base excess. The pH is a measure of how acidic or alkaline the blood is. The PaCO2 is the partial pressure of carbon dioxide. The PaO2 is the partial pressure of oxygen. In practice, we usually omit the little a for both of these and just refer to them as PCO2 and PO2. The HCO3 is also known as the bicarbonate, or bicarb for short. SaO2 is the oxygen saturation as measured from the blood gas, as opposed to SpO2, which is the oxygen saturation from the pulse oximetry. The last value is the base excess, which is a measure of the amount of acid or base units that need to be added to restore the pH back to normal. When it comes to ABG interpretation, the first four values are the most essential. In medicine, we use a lot of various terminology. Oftentimes, we use different words interchangeably even though they technically have different meanings. For example, hypoxemia versus hypoxia, acidemia versus acidosis, and alkalemia versus alkalosis. The type B personalities won't care that much, but the type A personalities who pride themselves on being precise should pay attention to this section. First, let's differentiate between hypoxemia and hypoxia. Hypoxemia is a reduction in oxygen levels within the blood. This can be objectively measured by the pulse ox or an ABG. Hypoxia is a reduction of oxygen within the tissues. This is more of a subjective pathophysiological state since we generally can't measure oxygen levels within the tissues. Hypoxemia can often lead to hypoxia, but tissue hypoxia doesn't necessarily result in hypoxemia. For example, you can have an ischemic organ but still have a normal pulse ox. Moving on to acidemia and alkalemia, like hypoxemia, these are objective, binary conditions of the blood. They are used to describe a state where the pH is either too high or too low, so it can't be both at the same time. You're either acidemic or alkalemic. The OCs, acidosis or alkalosis, are pathophysiological processes occurring within the body. Because they are conditions and not a state, you can have an acidosis and alkalosis happening simultaneously. Every nurse knows that we breathe in oxygen and breathe out carbon dioxide. Regulation of these two gases is essential for proper metabolism and homeostasis. Oxygenation, as measured by the PO2, ranges from 80 to 100 millimeters of mercury. Ventilation, as measured by the PCO2, ranges from 35 to 45 millimeters of mercury. The ABG tells us about the gas exchange happening in the lungs. The oxygenation and ventilation values are often used to guide mechanical ventilator management. We check an ABG, then adjust the settings to try and bring the values within a normal range. I think oxygenation is the easiest part of the ABG to understand. If the PO2 is low, give more oxygen. If it's high, decrease the amount of oxygen you're giving. Please don't forget that there is such a thing as too much oxygen. Give the lowest amount of oxygen necessary to maintain a normal saturation and prevent oxygen toxicity. If a patient's PCO2 is abnormal, we need to modify the patient's minute ventilation, or the total amount of air that they breathe within a minute. This is achieved by adjusting the respiratory rate or the tidal volume. Increasing the minute ventilation will blow off more gas and decrease the PCO2, whereas decreasing the minute ventilation will retain more gas and increase the PCO2. It's actually fairly simple once you finally understand it. Now on to the fun part of ABGs, acid-base analysis. Remember from middle school science class that acids and bases are substances that donate or accept hydrogen ions. Acids and bases are functionally opposite of each other and they can chemically neutralize each other. To interpret ABGs, you must first understand the components or values of acid-base analysis. We need to look at the pH, the PCO2, and the bicarb. To reiterate, the pH tells us the actual state of acidity or alkalinity of the blood. The normal range is 7.35 to 7.45. A value below 7.35 indicates the patient is acidemic. A value above 7.45 indicates the patient is alkalemic. Next is the PCO2, which is rapidly regulated by the lungs, making it a respiratory process. Carbon dioxide is functionally an acid within the body. So when you hear PCO2, think acid. The normal range for PCO2 is 35 to 45 millimeters of mercury. Because CO2 is an acid, when the amount of acid is low, the blood will become more basic or alkalotic. When the acid values are high, it will make the blood more acidic. The HCO3 or bicarb is slowly regulated by the kidneys, making it a metabolic process. Bicarb is functionally a base within the body. When you hear bicarb, think base. Because bicarb is a base, when there is less than normal base, it will make the blood more acidic. And conversely, when there is more base, the blood would become more alkaline. Got it? Now that you understand the respiratory and metabolic processes in the body, you should be able to determine that there are 4 disorders of acid-base: a respiratory acidosis, a respiratory alkalosis, a metabolic acidosis, and a metabolic alkalosis. There are numerous methods on how to interpret an ABG. Although I want to hate it, the tic-tac-toe method is probably the best for new learners. You can find videos on this method all over the internet. But because I'm a rebel, I'm going to take a very similar approach, but modify it so I can claim it as my own. First, write down pH, respiratory, and metabolic. Then, as you read the values of your ABG, write down either acid, base, or normal next to it. When you find the one that matches the pH, that's your primary process. Let's do some practice examples now. The conventional sequence is to list the pH, PCO2, PO2, and bicarb. In these examples, we will just ignore the PO2 since it isn't relevant to acid-base analysis. Using my approach, we see the pH is low, so we have an acid. The respiratory process is high, which is also an acid. And the metabolic process is normal. So the final verdict, we have a respiratory acidosis. In this next example, here the pH is a base. The respiratory process is within the normal range, and the metabolic process is a base. Since the metabolic process matches the pH, this is a metabolic alkalosis. Here we have a normal pH, a normal respiratory process, and a normal metabolic process. This is a stone-cold normal ABG. There is nothing pathological occurring in this patient, and we probably shouldn't have even checked an ABG on this patient. Those already familiar with ABGs know that we also look at something called compensation. The body can only function properly when the pH is within the normal range, and it will make every effort to restore the pH back to normal. It does this by compensation. When we have a primary disorder, we expect the body to compensate using the polar opposite process. For example, if we have a metabolic acidosis, we would expect the body to compensate by trying to generate a respiratory alkalosis through hyperventilation. Or if we have a respiratory acidosis, the body would try to generate a metabolic alkalosis by holding onto more bicarb. When we talk about compensation, we have 3 choices: uncompensated, partially compensated, and fully compensated. Let's look at an example of each. Here, the pH is low, so we have an acidemic state. The respiratory process is normal, and the metabolic process is an acid. So we interpret this as a metabolic acidosis. We know compensation happens with the opposite system, so going back to the PCO2, we see it is normal. Because the lungs don't seem like they're trying to make things more alkalotic, this is uncompensated. We have an uncompensated metabolic acidosis. Here, the pH is on the side of base. The respiratory process is an acid, and the metabolic process is a base. So this patient has a metabolic alkalosis. But you can see the opposite process, the respiratory CO2, is quite high. So this indicates that the lungs are trying to compensate by making the blood more acidic to bring the pH back to normal. However, as we can see, the pH is still out of range. Because the body is making an attempt to correct the pH but has not fully succeeded, this is considered partial compensation. This is a partially compensated metabolic alkalosis. Here, the pH is actually normal. We're done. Or are we? Let's make sure we review the other numbers before jumping to conclusions. Looking at the respiratory process, oh, it's an acid. And the metabolic process is a base. Normal, acid, and base. There is no match here. Well, in this situation, rather than using a range, we need to choose a singular number as our center point. For the purposes of interpretation, we will use 7.4 to be the perfect pH. Since the pH falls below 7.4, it is leaning slightly more toward acid, even though it is a normal value. So if we consider the pH to be more of an acid, now we have a match, and we can call this a respiratory acidosis. As we would hope, the body has generated the compensatory opposite process as evidenced by the elevated bicarb. Because the pH is back within the normal range, despite a primary respiratory disorder, we can call this a fully compensated respiratory acidosis. Let's try one more for funsies. The pH looks like an acid, the respiratory is an acid, and the metabolic process is also an acid. This is a little different. What do we call this one? Since both the respiratory and metabolic processes are an acid, this one is called a mixed respiratory and metabolic acidosis. And that is basic ABG analysis. As a nurse, you actually have it quite easy. You just look at the numbers and give it a name. For physicians and advanced practice providers like myself, we have to apply a more advanced approach to ABG interpretation. It's not enough to just say, this patient has a metabolic acidosis. I have to figure out what is the cause of the metabolic acidosis and how best to treat it. And I don't mention that as a flex. I'm actually about to red pill all of you nurses out there. Brace yourselves. The ABG interpretation that you know and that I just reviewed is actually not entirely correct. I taught it to you this way because this is how you will be tested on it. But in real-life practice, there is actually no such thing as partially or fully compensated. Rather, in advanced ABG analysis, we look to see if there is appropriate or inappropriate compensation. My mind was blown when I first learned this. I'm not saying that nurses are wrong per se, but I just wanted all of you to know that ABG interpretation is far more complex than you may have realized, and don't be surprised if a physician is explaining something to you that seems a little different than what you were taught. If this piques anyone's interest, do a search on ABG compensation formulas. You'll find out about Winter's formula, acute versus chronic compensation, the anion gap, the delta gap, etc. Thanks for sticking around to the end. Hopefully you feel pretty good about your ABG skills, but if not, don't worry. You will get better with more practice and experience. If any of you geniuses already knew about the partially and fully compensated fallacy, let me know in the comments. Please give this video a like so it can be pushed out to more eager learners like yourself. Also, consider subscribing to my channel so you don't miss out on future videos. Okay, thanks. See you next time.